Dr. Lanier from Cutting Edge Foot and Ankle Clinic. You are listening to the MedNation podcast. Dr. Fernandez in surgery is going to join us shortly. Our podcast involves two podiatrists having conversations with industry experts for people who love to learn about everything from head to toe. Today, we invited another excellent podiatrist to our show, Dr. Chiu. Dr. Chiu is a board-certified podiatric specialist for foot and ankle surgery. He specializes in diabetic limb salvage. Before starting today's conversation on limb salvage, Dr. Chiu, can you introduce yourself to our audience, please?
Yeah, hey, my name's Haywan. I've been a podiatrist for 5 years now since graduating residency in 2016 from VA Palo Alto. And right now my practice is pretty much 100% limb salvage. That's pretty much all I do now.
That is excellent. So we were talking a little bit about this before we started recording. Tell me a little bit your steps before just doing limb salvage. I know you have worked for a hospital before, and then you work for the VA. Explain on that a little bit.
Sure. So I guess I'll bring it back to when I was in podiatry school. You know, as a pre-med podiatrist, I was required to shadow a podiatrist to get into school. And at the time, I shadowed Amal Saxena, who is a world-renowned sports medicine podiatrist. So, you know, I was pretty into sports. I was competing in triathlons in college, and I was thinking going to podiatry, I'm going to be like a sports medicine podiatrist because I didn't even know anything about the wound care and medicine involved. So throughout podiatry school and then, you know, into residency, I was still thinking I'm doing sports medicine until my first year of residency. I was learning all of this medicine at VA Palo Alto. We're affiliated with Stanford University. So I was learning a lot of medicine from Stanford medicine attendings and residents. I was learning a ton of all the, you know, intricacies of what involves in the human body, and it gave me a good appreciation for the sickness that patients are having. And when we had a diabetic foot infection that my attending did a source control surgery, but you know, when we're doing bedside rounding the next few days, it just was nothing was healing. So, and being the first year intern at the time, it was on me to tell the patient that we had to recommend a below the knee amputation. And it was such a profound moment that's when I pivoted from sports medicine into limb salvage. I felt like we're changing lives, you know, getting athletes back on their feet, doing their sport, but it's a whole different feeling if you're able to save someone's leg and preserve their life, you know, extend their duration of life, or to save their life when they're dying from infection, quite literally. I think, you know, it just feels a lot more profound, the type of work that this involves. You know, there's a lot more inconvenience because I can't just schedule, you know, emergency surgeries when I want to. I have to do it when it happens. But that's also part of the more rewarding part of doing this, is that we're there at their worst of times and we're there to get them out of it. And the amount of appreciation that I felt from those patients when they're recovered and they're through, you know, got them through the hardest part of their life. You know, for some patients it is. That feeling just so rewarding that's when I decided that this has got to be what I'm going to do for the rest of my life.
I can relate a little bit on that aspect as well, because as podiatrists, all of us are trained to do wound care to some level, and there are some instances in the hospital, you know, being on call, you're going, seeing those patients that are some limbs, you know, they are not salvageable, and you have to have that discussion with patients, and it's just very hard, breaks your heart. This is a patient, especially the young patients with diabetic and non-compliant. You're telling them, I'm just going to consult vascular, you have to lose your limb. It's been practicing 3 years. That's been the hardest discussion I have to give every time.
Yeah, it's never easy, and that's something that not a lot of the general public is aware that we do, that we podiatrists aren't dealing with on a regular basis. Yeah, it's a hard conversation. Over the years, I've gotten more comfortable with it just because we all deal with this stuff. And I think when it comes to limb salvage versus amputation, like a lot of times these patients are so sick that it's sometimes not even worth going through the salvage, right? Like they go through so much with surgeries, repeat surgeries. Sometimes they just want to be home and be done with it. And amputation may be the better way to go.
Yeah, that was the discussion I had one time with our infectious diseases guy. Felt like he was pushing most for amputations than limb salvage. And I explained to him, what was his reasoning. And he's an infectious disease guy. He said, I look at it this way: it's either the kidney or the limb. If you're gonna do limb salvage, you have to have the patient on long-term IV antibiotics. They are already diabetic. They already have complications. They're gonna shut their kidneys and they're gonna be on dialysis. So either that, or let's take care of the limb, and we will save the kidney.
Yeah.
What's your intake on that?
That's a good point. Like, I guess it's almost like up to the patient sometimes too. You can almost describe the scenario where, all right, sir, like if you want to save the leg, your kidneys are gonna die and you're gonna need dialysis, which means 3 times a week you're sitting there for 4 or 5 hours doing dialysis. Or if you want to save your kidneys and avoid that, we can cut your leg off. And now every day, if you want to walk, you're putting on a prosthesis to walk. It's like pick pick your evils. It's it's pretty morbid, and I think it's a terrible situation for a patient to have to decide between the two. At the end of the day, these are all just chronic disease that we cannot reverse, and these are all measures just to try and preserve their life and give them some way to continue living, even if it feels drastic, but it is life preserving.
Absolutely. So for your non-compliant diabetic with superficial ulcers, wounds, obviously you always are worrying the worst case scenario. Is there a conversation you have with them to avoid further deep infections, for them to understand the magnitude of the problem, the problem they can have just by being diabetic, and now they have superficial ulcers?
Yeah, is there a question like, how does a conversation go when I first meet them?
Yeah.
Yeah. I mean, like when I get a new wound in the office, I find people they just don't understand why it's there. They're like, I've been diabetic for 10 years and I never had a wound until now. It's got to be the shoes. I probably got these shoes last week and that caused it. While that may be partially true, I do spend some time in the front end to educate them on the years of disease that led up to this moment. And sometimes it might take me a while to get through to them, and it might take repeated educational sessions for them to fully understand. Because it's a lot of information. It's hard. They're living with this complex disease, and to be able to fully educate them in a 10-minute appointment is not possible all the time. So I just be patient. I try and use as much layman's terms and break it down as simply as possible so that they can get the key points they need to understand their disease.
Yeah. Do
Um,
you get
yeah.
do you get a lot of receptiveness from patients in general, or
Yeah,
they are usually defiant? Oh, that would never happen to me.
I mean, yeah, I get the full range as you do too, I'm sure. Like there are some patients that just refuse to understand or to refuse to believe what I'm telling them, or they're just not hearing it. Sometimes there's mental illness that prevents them from fully comprehending even the most simplest things. Yeah, there's a lot of challenge with just the educational part, but I do my best to give that education. And if there's family, usually they're the ones who's comprehending it and then giving it to the patient, throughout the next few days to help them understand. But yeah, I think it's important for them to understand and fully buy into what's causing the wound, and then they can understand why these treatment that we're offering are going to help them.
Absolutely. A lot of people, they don't know what a diabetic limb salvage podiatrist is, or tell us your steps, tell us your process of what you do in your clinic on a daily basis.
Yeah, so podiatry is kind of a unique specialty where we have subspecialists within our profession. And to be a diabetic foot limb specialist or there are some fellowships that give you more training in doing diabetic limb salvage that will make you a little bit more experienced in it. But honestly, for me, I didn't have fellowship training. I just did more of it than anybody else around me, and that's what made me kind of hone my craft. In order to do that, I gave up other parts of podiatry that other people would still trying to do, And so that involves not doing elective bunion or hammer toe surgeries or flat foot reconstructions anymore. All I do is bulk of my work is in the hospital, where I am taking call for the hospital, where anything that comes through the ER or admitted to the hospital that has a diabetic foot infection, they're calling me. And if it needs emergency surgery, I'll be available to do it. And I'll be the one also taking care of these patients after they're out of the hospital and in my clinic, where I'm gonna see through see through to the end for the patient and get them through that infection and getting the wound healed. So it does come in waves, my clinic, where when I'm on call a lot, I have all these new patients coming in, and when I take like 2 months off call, my clinic starts to get a little bit easier as wounds start healing up, and then go back on call again, and I get a wave of patients. That's kind of the flow of it. And I see patients almost part time in clinic, where it's usually half days, especially on days when I'm on call. I'll see anywhere from 10 to 25 wounds in the morning, and then I'll be available in the afternoon to do emergency surgeries or see consults in the hospital if necessary, or just spend time with my family if it's kind of a light day. That's pretty much how my week goes.
You mentioned that the reason why you got into podiatry was sports medicine. Do you miss having to, now that you don't do orthopedic surgeries, do you miss doing them?
Well, not really, because I came out of residency just focusing on limb salvage, and so I never had a robust sports medicine clinic to miss. you
Yeah.
know, so while I've done some in residency and done a few electives as an attending, um, it eventually what you do a lot of becomes your comfort level. So for me to do a bunion surgery on a totally healthy patient, I'm almost going to feel a little bit more uncomfortable than if I was to do a necrotizing fascia case up the leg, because that's what I do.
Yeah.
So, and I'm happy with that's fine. I think that's the best way for us to hone our crafts and to best serve the community.
Absolutely.
Because, yeah, I'm like the only guy in my community that does 100% limb salvage, and word gets out if you're the only guy that does something. So I get a lot of referrals from people who have post-surgical infections or complications. They'll send their patient to me, and I'll help them get through the wound to get it healed, or take care of the infection, or what have you. So I think it's kind of a cool camaraderie we have. My partners are all sports medicine, trauma, and reconstructive docs, podiatrists, and we share patients all the time. Sometimes there's a complex neuropathic foot wound that needs a full reconstruction that is a little beyond my skill set to do, and I'll refer it to my partners to do, and I'll take care of the wound. So there's a really good camaraderie. Like it's cool that these subspecialties within podiatry can still coexist within the same clinical environment.
Absolutely. I'm sure some of your partners, they don't like seeing patients with wound. They don't like dealing with wound. One of the things about wound is it's hard. You have to have patience. You have to have time for it.
Yeah, it's a whole different feel. Like, yeah, as you do you see like a mix of everything yourself?
Yeah, 50% of our patients are diabetic wound patients.
50%?
Yeah.
Okay. I mean, yeah, for me, sometimes I'll see like a random heel pain or hammer toe pain, bunion pain. If the other docs are not available and I have a slot, then they'll schedule them to see me. I'll give them the initial spiel, and then I'll refer them to my colleagues. It's always a weird feeling when I've just debrided a massive wound. They're bleeding in my office, and nothing's hurting. And then I go into the next room, and I'm touching the bunion, and they're jumping out of their chair. It's like, okay, like, all right.
You're like, what? You're not neuropathic?
Not that I don't have empathy, but it's just a whole different, like, they're at different states in their lives. One patient is on their way towards terminal illness, and the other one has a whole lifetime ahead of them that they want full functionality out of.
Right.
It's a different feeling, and the equipment needed to manage these are different. Like the DMEs to manage sports medicine is different than all the curettes and scalpels and gauze I'm going through for these wounds.
Right.
So inventory is a little different, but we've done a good job of kind of, my wound care isn't, I don't use a whole lot of product. It's
Do you
all
use
mostly
any graft? Do you use any graft?
not a whole lot of. Usually a good debridement or addressing the biomechanics or just making sure it's clean gets a lot of my wounds healed. There are some wounds that are so stubborn that having the basics covered that don't heal, that I'll send a insurance pre-authorization for and apply a graft like weekly or every other week. So I do it sometimes, but it's not a big part of my practice.
Oh, really?
Actually.
I would assume that would be, since you see a lot of patients with wounds. Again, but like you said, it's what works for you. Good debridement and staying off of it, good blood flow, controlling infection, obviously, can make a wound heal faster. But most of our patients seems like they're chronic diabetics. They need that little bit of support from a graft. It's acute wounds. I'll be able to heal without a graft.
Yeah. No, it's. I think a lot of people are similar to your responses. Kind of surprised to hear that I don't use a ton of grafts.
Yeah.
I think the majority of the graft I do is in the hospital, like scaffold grafting, like
Right.
Dermacell, Integra, Stravix, stuff like that.
Right.
And that's just to cover tendon and bone.
Right.
But once they're granular, a lot of times I just go with regular weekly debridement and dressing changes on these wounds, and they'll epithelialize just fine. Or I do a split thickness skin graft to get them healed in 2 to 4 weeks.
Yeah, absolutely.
Yeah.
So your healing rate is pretty high.
I mean, I don't know. I think wound care is so complex. Like it's hard to say like this guy's healing rate is much more than others. Or we have different demographics too. Where do you practice?
Tennessee. A lot of people
Okay.
like fried chicken.
Yeah, I mean, New Mexico is one of the poorest states, and I don't know like the economics of Tennessee, but like in New Mexico, education and there's a lot of property theft because of the educational level and the poverty here in general. So a lot of my patients just struggle with being able to make it to the appointment, or I mean, there's a scarcity of physicians here too. So a lot of them are traveling from several hours away, and they're, with gas being so expensive, they're reluctant to spend the money to come in and see me on top of their deductible and their copays. Understandably, it's hard.
Right.
And that's a big impediment to wound care access for some of my patients that I can't help. And obviously, they're the ones that are having these complications and their wounds getting infected and winding up in the hospital with all these issues. So yeah, I mean, yeah, I'm sure my healing rate is terrible if you look at all that.
No, I tell you, there are times with wound I get discouraged and like, am I going to heal that heel?
Oh, 100%. Yeah, and like there are some wounds or infections in the hospital that you do a surgery on and it's just kind of dusky, doesn't look quite right, and it's not like fresh bleeding on the edges that we want because of vascular disease, and they just get kind of dragged on and multiple admissions and lots of wound care. And what I tend to do is on people with vascular disease, their infections tend to be worse. And oftentimes I find that my colleagues are reluctant to do the necessary source control steps to control that infection because you're going to create a big wound. And with them having vascular disease, it's going to be hard to heal. So a lot of times residual infection is left, and the vascular is consulting me for like a second opinion, and I'm coming in there when their foot's already half rotten, and by then it's already BKA. So like when I get those challenging cases, I usually right off the bat, I'll tell them this is going to be at least 2 surgeries, possible vascular intervention. You're going to have a wound for 6 months to a year, possibly. And throughout that entire time, it can get infected at any time. That makes all of this surgery and this hospitalization completely, moot, where it's useless because you just get reinfected again, or you end up losing your leg. With all that said, I totally undersell it. And if they still want to proceed to do limb salvage, then I know they're 100% bought in.
Right.
They're going to do whatever it takes. But if they're like, oh, no, I don't want to pick the line. I don't want being poked and prod. I just want to go home. To me, that's a BKA.
Right.
So perfect segue into limb salvage. Hey, Dr. Chiu, how are you?
Hey.
Good morning.
Hey, Dr. Fronin, how you doing? How's your
Yeah.
case?
Oh, the case was beautiful. I took your TMA steps that you
Uh,
do, and I did the Dr. Chu TMA experience actually, and it turned out flawlessly. May I add?
oh man, awesome. So happy to hear. Are you subscribed to FASA?
I do, my friend. Yes, I'm a big fan of you guys and your colleagues, or you especially, and what you do and your colleagues. And I think it's fantastic for residents. I really wish that even when Dr. Lanier and I were residents, that you had something like that going, because I think you're making leaps and bounds for young residents, medical students, and some young attendings alike. So,
Oh, awesome. I'm happy to hear that. How was it you use a McLamry scoop and
yep,
all that?
yep. The Dr. Chu technique. It went beautifully. So now I just
Awesome.
as a vascular path and end stage renal and hemodialysis. So now we just of course cross our fingers and hope,
Yeah,
because those patients are particularly fragile and difficult to
those
begin
for
with.
sure. Yeah, I mean, it sounds like you've done everything you can to leave a nice vascularized bulk for closure. I
Yep.
mean, as long as bones close, you're good, right?
Yeah. Yeah. I mean, well, theoretically, yes.
Yeah.
But yeah, so
Yeah.
thank you for coming on with Dr. Lanier and I. And again, I apologize for my tardiness. I know I got the tail end of your conversation, about limb salvage and your thoughts and such. Um,
Yeah.
Dr. Lanier, tell me, where do we leave off?
We are right when we're gonna talk to him about his website.
Oh, but look at that, Dr. Chu, you and I.
Yeah, there you go.
So the foot and ankle surgery academy, Dr. Chu, like I said, it's been a blessing, and I promote it heavily to folks, young residents in my residency and stuff like that. I highly encourage them. So tell us a little bit about the website, Dr. Chu, and kind of your thought behind it and creating it.
Yeah, I mean, it's really at the start of the pandemic in early 2020 where all this craziness is happening. The world shut down. Medical education also just shut down. There's no electives. Students and residents were no longer allowed in all the hospitals and operating rooms that we do surgeries on. It's like, man, like this isn't just going to go away. This pandemic is here to stay for a while. And with medical education hit that hard, I felt something had to be done. And like I couldn't just sit there and just let this happen. I felt like something needed to be done. And I felt like I was in the perfect position to do something because I was just six months into my private practice. And as you guys are in private practice too, right?
Yeah.
Yeah, I mean, folks in private practice, we don't get patients handed to us. We have to work for it or to build our practice, and it's usually a slow process in the beginning. Even though I was taking a ton of call to build my practice, there were still days when I don't really have a busy schedule. So usually my partners, Dr. Haas and Dr. Kopp, they are roughly 8 years ahead of me. They are phenomenal surgeons, and I initially scrubbed with them every Tuesday because that's their block time, and they're usually filled with like at least 7 cases of elective surgeries, and they they do. So I did that just to get RVUs as an assistant, just to build private practice, and I was learning so much just scrubbing with them, and they are also the docs in our community that are usually the second, third opinion guy that to go to for like questions and complex things. They're also doing total ankle, so for me to see the skill that they're displaying is really cool to watch. I'm learning. They're passionate about teaching, and they've always had this idea of filming video on surgery on their mentors. So I was like, okay, well, I'm just scrubbing these guys' cases. Why don't I just buy a camera and film it and see what we can come up with? My first step was to go to YouTube. Of course, there's nothing on how to film foot surgery on a live patient. There's no like gear recommendations for any of this stuff, and I just kind of studied what I could from YouTube and figured out some kind of camera system. Figured out how to mess around with camera settings, ISO, and all that sensitivity and f stop, all that stuff. Figured out what it meant, and then I tried to film a few of their cases, and it turned out pretty good. So then I had to figure out how to do audio editing, and YouTube's pretty amazing. You could learn almost anything there. Eventually, I got a ton of surgery raw footage. I found 10, or I did 12 like voiceover videos, and decided to just launch it as a online subscription course website. So our initial pricing was like $20 a month for the access to these 12 videos, with the promise that we will continually to edit and produce videos each week. And for the past year and a half, we've been all kind of just cranking out videos weekly until we're at over 100 videos now, like 70 plus surgeries.
That's great.
At a $20 a month offering. So it's been pretty, I think, worthwhile for folks to get access to these. And initially we were thinking this is going to be good for students and residents who didn't have access to it. But then we found a majority of our audience were actually young attendings who wanted review on stuff or to get tips, because when students are in residence, when you're scrubbing cases, it's not your surgery, so you're not particularly paying attention to certain details that you may have missed. But after you've done a few of your own cases, you're like, man, like, how much of that lateral capsule should I have released to get this bunion over? Like, let me just look at this guy's video, and you're paying attention to very specific things. I think, like, I don't know if that's true, but like for me, I find myself also going over some of this footage and looking at like fine details of how my partners did a particular maneuver, and finding it helpful for me in my practice.
Absolutely, any kind of help like that, especially like you said, new grads. In residency we have that blanket. Our attendings are doing this with us. That's not our patient. I'm not going to be sued, but right. I remember my first year out of residency. That was very frightening. It's really awesome for you guys to put the time and effort into creating educational content for the future podiatrists out there. So good job doing that.
Thank you. It's been fun. It's kind of like, I mean, most people do hobbies outside of podiatry, and this is like, it's a lot of video editing, audio editing, a little bit of entrepreneurship and business, and some social media marketing and all that stuff. And it's been fun. Like, I can't get tired of it.
Yeah. So Dr. Chiu, talk to us about, as we come to a tail end, do you have a particular inspirational quote or mantra that you follow every day that you can tell young surgeons, young residents, young medical students, and just young professionals that listen and subscribe, because we have quite a subscriber base, as well as older attendings as well, and older medical professionals that you follow every day?
It's kind of a hard pill to swallow for a lot of people, but what you learn may not be the most correct thing. And just look at the example of history where, at one point we all thought the world was flat, but it's actually round. And we didn't know that bacteria was a thing until people became septic and died. And then we learned washing our hands should be like a thing. I think we're still evolving, and having the wherewithal to recognize that and adjust your own like understanding of the world is a hard thing for a lot of people. But that's really what kind of will set you apart. So the quote that I will leave you with is that I grew up with a lot of influence from Bruce Lee. He's like breaking barriers as a Asian American man in Hollywood, when that was never heard of as a thing, and he didn't care. He just did what he had to do. He's also a martial artist who was taught like different moves belong to different. Karate had a set of moves, Kung Fu had a set of moves. He didn't care about that. He wanted to do what he needed to do to win a fight in the streets. That's what matters. And kind of similar with like in diabetic limb salvage, it doesn't really matter like the rules that you think you learned. What matters is what works. And for me to be flexible in the OR to the circumstance that you're encountering has been very helpful for me to get my results.
I love that, and I agree with everything you said.
Yeah.
Play with wounds. So
be water, my friend.
you just have to pray as you read them. Well, thank you so much. You are, I love talking to you. I'm sure Dr. Farnan and myself would like to have you on and talk to you even more. I love the work. We love the work that you're doing, saving one limb at a time. And thank you for your time.
Yeah. Hey, appreciate it.
Yeah, thank you, Dr. Chiu. So everybody, thanks for listening to the Med Nation podcast with your host, Dr. Farnan and
Third linear.
And we hope you enjoyed our conversation with, of course, the wonderful and ever so talented Dr. Chiu. If you hear more conversations, or if you like and want to hear more conversations like this, join us for our next episode. As always, you can head over to Apple Podcasts or Spotify and to hear more episodes like this. If you have any questions for Dr. Chiu and or us, check out the links in the description below and feel free to email us and connect. Thank you for a wonderful episode, and see you all next time.
See you next time.